irritability. And historically, he would have had an aggressive meniscectomy. But what we did for him is, you can see here, there's a flap element to this complex tear. And we debrided only the white zone of the meniscus, leaving two large flaps, a bit like a fish mouth. So you have a superior leaf and an inferior leaf. And we rasped the tear to freshen it up. And we then do stitches top to bottom, vertical matrices, and we close the fish mouth. And we achieve a repair. Very different to that footballer I showed you before, who lost a lot of meniscus. But bearing in mind, he lost a lot of meniscus because he had an irreparable tear. This is a repairable tear, so we're saving volume. And then we go to the notch, and we do a non-articular notch microfracture to release bleeding and stem cells from the marrow. So this is called non-articular microfracture. Sometimes it's also called marrow venting. And this is to make the knee environment pro-healing. So to conclude, we still await some more long-term results, but meniscal repair definitely improves prognosis, function, and outcomes. And partial meniscectomy is not a benign intervention. Arthroscopy patients must be stratified, and meniscus experts should be doing the meniscus surgery. It shouldn't be generalists just removing the meniscus. And lateral meniscectomy carries a poorer prognosis than medial meniscectomy. And the lateral meniscus is more critical than the medial meniscus. Guys, that's the meniscus. Any questions? Samuel, I can't hear anyone. I can't hear, guys.
Wait, just wait. Thank you.
Welcoming questions. A question on the meniscus.
Thank you very much for the nice presentation. However, I didn't want to understand the outside and inside techniques. Maybe in a nutshell, just to summarize.
Okay, so I can't hear you. You would like me to discuss the outside technique? So the outside technique is a surgical technique that allows us to pass suture from outside the knee, not via the portal. It goes into the knee across the meniscus, and then we take that same suture back outside the knee again. So we call that the outside technique. The inside is done via the portal. So the suture goes in via the portal, and then the instrument and the suture goes in via the portal, out via the portal. And the inside-outside technique is a technique that goes in via the portal and then exits the skin separately. So the nomenclature and the naming of the techniques relates to the passing of the suture relative to the portal. Is that a bit clearer?
Yes, it's clear.
Thank you very much.
Thank you very much for your nice talk. I was just wondering whether you have any tricks for obese ladies with small knees as far as portal placement is concerned.
Yeah, good question. Good question. So we face similar challenges in terms of people who have a high BMI and a high body weight. It's important that we remember that, you know, we have to tackle their body habitus. So we must never miss an opportunity to politely, tactfully, and professionally advise these patients they need to address their body weight, because musculoskeletally and cardiovascularly, their weight is going to impact dramatically on their quality of life and their longevity. Surgically, there are no specific tips or tricks. The beauty is that once you're inside the knee, you know, it's actually quite straightforward because the knee is the same size on the inside. They do tend to have slightly bigger fat pads, which just require debridement for visualization. But prognostically, they don't do very well. So all of the negative prognosis around losing the meniscus, that's amplified 10 times over in the presence of a high BMI. So I'm sorry, I don't have any specific tips, but I recognize the challenge.
Thank you very much. My name is Mark. I'm glad the presentation was very nice, and I take home that when you're assessing the meniscus at arthroscopy, you need to look at the risks of failure to what you're going to do, and I've taken home the weight issue and the other injuries that could be attending the meniscal injury. I just wanted you to share with us how you handle the alignment of the knee and its implication to your outcome for meniscal surgery, and how you assess it, whether you do when you're repairing the meniscus, and how you decide to deal with it in terms of osteotomies and its implication to your outcomes. Besides, because I've seen you have addressed weight, other injuries, and the biology. Now this issue of alignment, what is your comment?
That is so. Please forgive me. That is an amazing question, and it's a very powerful question. That question probably will take 2 to 3 days to answer. There are entire courses on alignment and osteotomy, but I'll try and give you a very quick answer. And that is, osteotomy is a tool in our surgical armamentarium to treat the early failing unicompartmental disease. So either the early failing lateral compartment or the early failing medial compartment. If the patient has bicompartmental disease, they need arthroplasty. Where osteotomy comes in is it's a bridge. It's what, in fact, in my practice, I refer to it as a salvage operation. So we use it to salvage people who are too young to have a knee replacement, but they are too symptomatic to live without surgery. So if you're too young to have arthroplasty, and your symptoms are too severe to live with, and you cannot live life, and your disease is unicompartmental, then osteotomy is a good option to consider. And then, of course, there are discussions around how to do the osteotomy, which level, how much to correct. Do you live correct on 1 level, 2 levels, and various strategies around that. But osteotomy comes into the equation after meniscectomy, after meniscus loss, after chondral wear, and when the patients have significant symptoms. So guys, look, we've come to the end of our session. I'm so sorry we didn't have more time together. And once again, I'm so sorry that I wasn't able to be with you today. It's been an absolute honor, pleasure, and privilege to join you this morning. I hope you have a fantastic day of talks, lectures, and practical sessions. And I'd like to extend my thanks, my gratitude, and my love to Professor Samuel, and my respect to Professor Samuel for leading on this amazing educational endeavor. Thank you, Professor Samuel. Thank you, team. And I look forward to seeing my brothers in London in November. God bless.
Thank you, Adil. Thank you.
The next presenter will be Dr. Sabas. Dr. Sabas is an orthopedic surgeon in right here in Moi. He has an experience in arthroscopy for more than 5-6 years now. Welcome, Dr. Sabas.
morning. As Dr. Brita has already introduced me, that's my name, Joseph Sabas Santani. I also thank God that to be here, and it's my privilege to stand in front of you to have these few minutes talking about arthroscopy. Since we had this basic course, so we thought that it was important to mention about the education for arthroscopy. And we wanted to put this nice picture of our hospital. So I welcome you all, for those who are coming from Kenya and other countries, welcome to our institution. So I would like to take a few minutes actually to go through this case. We had a 36-year-old female who came to our emergency with a history of left knee pain, right knee pain actually, which was, she had sustained the injury 3 weeks prior. She sustained it while she was playing, and at her emergency, the assessment showed that she had swollen knee, limited range of motion. She could only flex to 90. She had some tenderness around, and other tests could not be elicited because of the pain and everything. So, Dr. Paul is here? Paul Sawat. How will you approach this? With the emergency and this late come? With that history.
For this case, with the history given there, I would request you for knee X-ray.
Okay, let's stay with the mic. We go through together. Okay. So it's fine. Orthopods, X-ray is part and parcel of our tool. So this was the X-ray. Can you comment about the X-ray now? Anything positive? What do you say? Any diagnosis you have there? Anybody else who can help? Paul, Christopher, anybody? Baraka, anybody? So, I'll say, if I say it's a normal knee X-ray, relatively normal knee X-ray, do you agree with me that it's a relatively normal knee X-ray? Anybody with a different opinion? Someone might agree that it's a normal knee X-ray. Huh? So we had this stage, like pain, she cannot fully flex the knee to three weeks down the line, post-injury. That's, we continued, we planned for continued resting, we instituted physiotherapy, giving some analgesic, hoping that she will improve. Some two weeks down the line, she still had pain, she could not flex the knee, and she could not bear weight. We tried to do some tests on the meniscal, for the meniscal injuries. There was not much positive, bacteria and everything, and there was not much instability, although that we could not really assess because of the infection of the knee. So we went ahead and do an MRI. So I tried to put some few images of MRI, and you could see, not fully, but at least on the you could see on the lateral compartment a little bit of the notch. Just pick some few pictures, and that's the medial T2 So still on the MRI, see some effusion. You don't see signal on the meniscus. Of course, if you go through all the series, there was not much contusion. So what could be the plan then, like here next? Continue physiotherapy, analgesic, knee brace, or what should we do now? So we discussed the pain, of course, that something's happening, let's go and do diagnostic arthroscopy. And this was our internal finding. The picture is not very good, but this we had a very big condyle lesion on the lateral femoral compartment, and the meniscus, all the meniscus were intact, and the ACL, PCL were all intact. So this is the piece of the meniscus that piece of the cartilage that it was floating compartment. So I think that now we have gone through, there's a lot of issues that what should be done to the condor defect and everything. But what we did, because it was loose already, we removed the loose cartilage fragment, and then we debrided it to make it smooth, and that's the option that we had at that particular point. And then now it's almost about 2-3 months now. She's walking in good range of motion, but it's not over yet. Okay. So this was just to start with. So as we have seen in the previous presentation, arthroscopy started about, I think, 19th century, and we won't be fair if we mention arthroscopy without mentioning the name of this Japanese professor, Ken Takagi, who believe that is the one who performed the first knee arthroscopy. Of course, then there's been another history of meniscectomy and various procedures for the knee, but this, when it comes to arthroscopy, I think his name is down in the history. So we all know that the arthroscopy, everyone is that we use the arthroscope comes from where that we want to look through the knee and sometimes diagnose and work in the knee. In simple terms, we have gone through about the anatomy of the knee. We know the ligaments, the tendons, the different structures, the articular cartilages, and everything. So I think the quick recap and why arthroscopy, that's what tells us why we want to do the arthroscopy. Mainly we do the arthroscopy because we want to diagnose and treating various problems of the knee. Because literally that's the concept of doing arthroscopy. So we can do arthroscopy in the case that we have seen the history, some performed clinical examination, and that we think that someone is a meniscal tear, then we can be done arthroscopy, as we have seen with a good talk from Wadil. Can be meniscectomy, can be meniscal repair, and all that range of meniscal treatment. So, cruciate ligament injuries. Of course, this is a picture of a normal ACL. This is not the other one I didn't put there. So we have the normal ACL, and then for ACL, PCL repair, I think we are doing many of them. And I'm told when my chief, who used to tell that sometimes when he was starting arthroscopy here, because even in Moi, we won't mention arthroscopy without mentioning the name of our teacher here. Started long back when we had almost but there was sometimes they did open up ACL construction, but now at least we have passed that. We're still doing some meniscectomy. We hope we get where Adil and our fellow in Kenya are, that we hope we are going through up the ladder. So we are also performing a lot of joint debridement here for arthritis. I don't experience in other areas because someone has arthritis already. Somebody want to delay. We know at the end of the day, that person might need a total knee replacement, but we want to delay that's what I believe. We want to delay the replacement probably. Someone needs to stay with his knee. So we are doing a number of diagnostic arthroscopy, and some of them we do debridement, removing all the loose cartilages and smoothing the cartilage and the like. Because, so sometimes you have someone with pain because of the inflammation in the synovium for various causes, might be infection, might be rheumatoid, might be bilonodal synovitis. So we are doing some arthroscopic synovectomy or debridement for this kind of cases. And as I've said, some various range of articular injuries or defects, it being abrasion or like debridement, mosaic and implantation. Although in our center with some of the procedures that can cut the implantation we haven't done, so we are still on the ladder. Arthroscopy also can be used when you have a malalignment of patella tracking, and can do some release arthroscopy rather than opening up all the knee. We also, I think, for those people who are doing total knee replacement or unicompartmental replacement, they would like to do arthroscopy before they do. Look at the other compartment they like, because you can do X-ray, MRI, but still might need to look at the knee yourself and see how is the other compartment before replacing the unicompartment. I think also some fractures, some tibial plateau fractures, we have done with our brother Felix here. that we do arthroscopy, and then it helps to give you a picture how is the defect inside then what you are fixing with the CM or whatever. Then. So arthroscopy also has a role in fixing some periarticular fractures in the knee. That's my talk. Thank you so much. Thanks for your time.
Thank you, Dr. Sabas, for a very elaborative talk. In case of any question, you are welcome in question.
Thank you, Dr. Sabas, for your talk. Very interesting. I just wanted to know if these patients in whom you do debridement for the knees and osteoarthritis, we try to pull them up and see for how long they stay pain-free after the debridement, maybe?
Yes, thank you. I think the most important thing is what degree the patient is. And what I've come to learn that even the morphology and what the patient does. There are some patients that you won't see them in clinic for 6 months, 1 year. They've done debridement, and then 1 year they are not back to using depending on medication. But really, we haven't done a study, but I think some of them really improve for quite sometimes 1 year.
Thank you. That was a nice 2-minute talk. That case you presented can be quite difficult. I wonder, did you have coronal sections of an MRI?
Yes, we had, but I didn't put them. We had all the series in my. We went through it. Yes, we had it.
We see them. Actually, it's becoming more common. I don't know whether it's an issue of diet or what. We are seeing more of those in young males, like school, for the ones who are getting growth spurt, 16-year-old boys at school. And sometimes on the X-ray you can see a small shadow where a bit of the bone has come off. So if you look carefully, sometimes you're able to see that, and then after you've done your clinical examination, you then have a suspicion that it's possible that is there. And of course, the MRI is able to show us coronal section. But they're very, very challenging to treat. So that was a good one.
Any other question? Comment?
Thank you, Dr. Sabas, for presentation. My question is on joint debridement for arthritis. So, which stages do you decide, or what factors make you decide to go for debridement?
If I respond to this, and usually if I would say there's someone has L-arthritis, like moderate arthritis and severe arthritis. The sense like I look at the joint compartment, starting from radiograph, like the X-ray. Someone has maybe still someone who has still preserved the joint space or weight bearing, or you are seeing like the arthritis or the osteophytes or the sclerosis is more on the one side, and it's maybe or in compartmental, or still you have even clinical, you still have some range of motion, and you don't have someone with severe osteoarthritis that is because then you go for the private. No, I think early to moderate might help, because someone maybe has a small cartilage lesion, then you graduate some osteophyte, and then has a early to moderate problem. I don't know what is the experience that
I think the issue is pain. When you're trying to treat this patient
the main complaint is pain. So there are many different ways on how to handle it. People go with injections, people try physio, and washout is another term that you have.
So that question has kept recurring, and I feel compelled to make a comment on this arthritis and debridement. In general, there is no indication for arthroscopy purely because of arthritis. It's a general statement, but because there is no benefit that has been shown that is useful, you did arthroscopy and you did debridement. However, patients who have arthritis and you are not yet at the stage where you are replacing, and they have mechanical symptoms, for example, loose body, or they have locking and stuff like that, you can go do arthroscopy for the purpose of unlocking that knee. But you do not book a patient who has arthritis, who you would have given an NSAID or a steroid injection for arthroscopy, because you have put in as one of the treatment modalities for arthritis. I think consensus now is that there is no role for arthroscopy purely for debriding arthritis.
Any other comment? Thank you very much,
Thank you, Dr. Mita, for this session. Okay, we are in strength of time. Our plan is to spin food you with lots of materials, lectures and then hands-on training. But we are late. That is, we are now going for tea break, almost 15 minutes to catch up with our program. What I request from you, dear colleagues, is just as fast as so that we can keep time, so that we can get enough to tell you. Thank you for that. Let's go for tea break, and just a quick one.
For the past 30 years, Professor Kale, when we were very young, we didn't have this gray hair which we have at the moment. We used to be few. The Arthroscopic Association was not probably there. We were meeting in other setups, but it's very much encouraging that today we are super specializing and going into these details, like in what we are doing here today. So MOI will always be part of that, locally in the region, and we are looking to be part of this endeavor internationally. And I hope our dream and the dream of young people, most of whom are here, will be realized, because there is nothing that is impossible to a willing heart. So it's just up to all of us to work hard, actually harder, with determination to achieve our objectives. The objectives of enhancing our skills so that we can provide much desired services to our patients in the areas of orthopedic and traumatology and their related subspecialties. Without taking much of your time,
because I understand you have a lot of things to do before the day ends. I would like to take also this opportunity to thank all of you, first of all, for the willingness you have shown of participating and eventually coming to attend this course. But this has been made possible by some very important and generous benefactors. Mega We Care is one of them. May we clap for our benefactors. They have been very generous with their donation and supportive donation to enable this event to be a reality. We have IPCA, and then we have ASAS. I understand this is from Iringa. They have also participated and assisted us. We have Double Medics as represented by Brett. I thought Gabriel would be here. Thank you very much, Gabriel and Double Medics. We have a global medical network, if I pronounce it correctly. Those who are helping us, linking our information and making us go into the best ways of communication. I would also like to thank my community in general, the management in which I sit, and the employees and all the staffs of Muhimbili Orthopaedic Institute for whatever they did to assist this event to be a reality, like provision of this venue and the rest of the venues, and allowing us to use their theater time. I understand all of us as surgeons, we know the difficulties we have when someone comes and takes your operating table, even for a day, but they have been willing to do that just to see that this event becomes a success. So I thank my community very much for what they have done to this cause, without forgetting the faculty. The faculty which has worked tirelessly, Dr. Nungu, Dr. Mrita, Dr. Helen, and the rest of the local faculty, which worked very, very hard to try and organize staff, laying down plans and such things. So we thank you very much for what you did, but without forgetting the international and the local regional faculty. I have a list here of those who came all the way from Nairobi and the rest of Kenya. We had Adil, unfortunately I wasn't here when he presented the Zoom, from the UK, Professor Ori, and the rest of the international and local regional faculty. Thank you very much for coming all that far to participate in our event. It is the hope of the hospital also that this is going to be the beginning of the good things to come in the area of arthroscopic surgery. We hope that such causes will be kept alive in near and future, and plus any other thing that will work towards improving and building capacity and broadening our knowledge in this age. And I also call upon, now that we have a lot of young people here, I've seen Penny Sama, long time, and Mage, and the rest, Lai, and the rest of everybody, in different areas as well. Now that you're omnipotent, you can excel in different areas as well. Our favorite spines, we have the arthroplasty surgery, we have trauma, reconstruction, and the like. So I believe the spirit which has been shown by this organizing the team and the cause in general will extend to the rest of subspecialties in orthopedic trauma, just to see to it that our field, much beloved field of orthopedic and trauma, becomes superior to the rest of the disciplines. So with these remarks, I declare on behalf of the hospital and the management that this course is open. Thank you very much.
Thank you, Executive Director. We will welcome you to come to visit our wet lab, the makeshift wet lab which we have managed to put together. That is one of the highlights of this course. to have a wet lab upstairs here. Please visit it to see what we have put up. Thank you for that. Asante sana.
Naomba mtoke nje tukapige picha pamoja.
I think we'll start in the next 5 or 7 or 10 minutes.
People have gone for children.
They're going to take a picture with the guest of honor.
Oh, okay. I couldn't follow what was happening.
Yeah, unfortunately, I think I forgot to switch on the audio. The guest of honor was here and then he was using the top. Now they're all going out for a picture. Just a quick picture and then we'll be back. That tea break is done.
Who is the guest of honor?
The executive director of the hospital.
Okay. Thanks.
Good morning, everybody. Hey, Changamkeni. Good morning, everybody. My name is Vincent Mwoki Mutiso. I'm from the University of Nairobi. Tumezoekea huko. First came to Muhimbili when it was completely new. Our first AO basic course was held in Muhimbili. I'm told this is not the building, it is another one. Is that correct? Yeah. And at that time, we were very impressed. It was a fantastic building. And one of the things also that impressed us, I was telling my colleagues, the Prime Minister was coming to open it. And you know, as we are used to people trying to be very flashy, so we expected motorbikes and many cars, and so on, noisy people, bodyguards. So we are standing there, and then a white Land Rover and a Mercedes, the smaller Mercedes came and parked. This is what was normal. So it's only when he came out of the vehicle that we realized that was him. And we were very happy. So I have good memories of this place. Right, to business. We are now on the second session. The one on radiological evaluation of the knee, which will be presented by our chairman. He is a little bit indisposed, and this will be presented tomorrow. Dr. Lutomia is here, and he will present ACL injuries. But however, we will start with Dr. Were, because it's a Zoom call and I understand he's ready. I think that is what we will start with. So shall we proceed? Morning, Dr. Were.
Morning, Dar es Salaam.
Incidentally, he was my student also, so you can see his humility. Karibu, Daktari.
Thank you very much, Dr. Mutiso, and thank you to the organizing committee for what looks to be a very good symposium. Mine will be to present on ACL reconstruction. It's a difficult topic because many people are conversant with the ACL reconstruction, and it's hard to, it's not like I'm presenting to a group doing the basic course. So I'll just try to focus on my arthroscopic method of reconstruction, but I'll touch on the other aspects first.
Recording in progress.
I hope you can see my screen.
Yes, we can see your screen quite well.
Okay. I'll just touch on the anatomy a bit. The issue of the two bundles, the mean length of around 3 centimeters with a width of 7 to 12, average 10 millimeters. There's also controversy about the double bundles. Some people say it's because of the shape, that it's not a rounded shape. So the shape it takes, it translates to bundles. But I think the accepted anatomy is the one for the double bundle, with the anteromedial and the posterolateral bundles. In terms of reconstruction, we look at mainly where we need to go through. So on the femur, we need to go basically behind the Blumenstadt line. Yeah, Blumenstadt line there. But the people who do double bundle try to focus to try to repair the bundles according to the attachment. But for us who do the single bundle, we try just to go to the center. As you see there, the center around the lateral bifurcate ridge. Again, that's just an illustration of where we go through. There are many methods of checking. There are many methods of confirming. You can do the ACL ruler. You can use, for me I use anatomical. I look at the lateral intercondylar ridge and the bifurcate ridge, then I go around there. There are people who use eye radiography or fluoroscopy, but for me I don't use that. Again, on the tibia, just to show the attachment point, these are picture from the net, but basically what we see, the anterior horn of the lateral meniscus can guide us. Alternatively, the medial tibial spine, we just go lateral to it. This is important so that we don't go too posterior or too anterior, because either of that will give a complication. If you go too anterior, it will compromise ACL function, and it will cause extension. So these are just some of the guides we use. The anterior border of the PCL, usually I find it not so clear as the posterior border of the anterior one of the lateral meniscus. So for me, this is what I use most, and the interspinous area of the tibial plateau. Again, in terms of treatment, maybe this slide should have come earlier. We can do non-operative. We can repair mainly if we get it early, but the mainstay of treatment of ACL tears currently is ligamentous reconstruction. People are going back to repair, but it hasn't picked as much. Again, we are still looking at outcome studies from the West to see how the long ACL repair. And this is based on age, activity level, demand, and other concomitant pathologies, which we'll see on a different slide. So once, as one of the presenters who comes to Kenya often used to say, the ACL will tell you when to repair it. That is when the full range of motion of the knee is restored. Going to repair it before this will really compromise your outcomes. In younger and more active patients, because of the activity level, it's better to repair because or to reconstruct rather. If you don't do that, then you need to be on a brace and restrict activity. So that doesn't work well for younger patients and especially children. So failure of prior reconstruction is an area I won't dwell on today, but it's usually occasion for reconstruction. So the concussion mentioned, the point to note is that most of these, if not handled, will compromise the outcome of the ACL reconstruction. MCL might be treated non-operatively. You can put it in a brace for some time, but if it's a valve around the femoral and the tibial attachments, then it's usually better just to go in and repair. Meniscal tears, you have to try to repair them. Chondral injury, posterolateral corner, and also if you have loss of, if you have impaired alignment, for example, the posterior tibial floor or a significant varus or valgus, then it's important to repair this. Otherwise, there will be a strain on your reconstruction and the outcome will be poor. So we can repair open or we can reconstruct open. Our open options are limited, but it's still possible, especially where there is no arthroscopy facility. But all in all, arthroscopic techniques are advantageous because of smaller incisions, less trauma to the extensor mechanism, and then we can view the notch and also have a look all around the joint, see the menisci more clearly, and all in all we have less postoperative pain, fewer adhesions. I'll mention a slide, I'll show a slide later that might disprove some of these, but all in all we have less postoperative pain. The issue of adhesions is more related to the indications, the decision on when to do the surgery, and the rehab. If you go on and do an arthroscopic reconstruction and don't follow the rehab appropriately, then you might get adhesions. Graft selections will be covered by Dr. Lutomia, so I won't dwell so much on this. Fixation strength, again, what determines our strength? We know the BTB is bone to bone, earlier healing. When we use the other methods, when we get the tendon to bone healing, then takes a bit longer. As this is just about BTBs and interference screws. Again, grafts will be dealt with by my colleague, but that's just a picture of a harvest tendon harvest, hamstring tendon harvest. I need to show it because that is what I use mostly my ACL reconstruction. Again, quadriceps, I don't use as often, but I've used a few times. I still find it easier to use the hamstring, so usually I go for the quadriceps when one is on another. I cannot easily get the hamstrings. So again, just a picture of graft preparation. These are we prepare our grafts after harvesting. The hamstrings we quadruple them to 4. Again, just fixation. Interference screws are the first ACL reconstruction I assisted in. We used this and harvested the BTB. This is a corticocancellous fixation. Can use staples, washers, crosspins, or indirect fixation. Again, cortical anchoring devices. This is what we use mostly, but this is the method we use mostly in our hospital. These are the endo buttons. We pull them and flip them. So we get a socket rather than a tunnel because this part is wider and the thinner part towards the cortex is where you pass the endo button and flip it. So the advantage it has is that you can bring the graft and fully fill this would now be the socket rather than the tunnel. So just a few videos. I've shown the graft harvest, the picture. So I'll show a video of what I do arthroscopically now after getting the harvest and preparing the graft. So as you can see, I don't know if this is not so clear, but we have the lateral intercondylar ribs there, so we go posterior to it. So that we yes, now we have it in the right place. This guide also has one of the methods we can use for getting the tunnel or the socket position is the ACL rule. This guide doubles up as an ACL ruler, so you check how far. If let's say you are at 14 millimeters, you know the socket will be too anterior. So this combines both the anatomical and the ACL ruler. Then now we drill from outside. There are various ways of doing this. There are people who actually do it even from the tibial tunnel. And then you drill with a wire and over drill with a drill bit. So for this one you go, and then once inside, because it's all inside, now it flips. So yeah, you flip it and you make the wider area for the socket now. So usually, in most cases, we measure 25 millimeters of the wider parts of the socket for the femur and 30 millimeters for the tibia. Usually, it gives us a bit of a shorter graft than what I mentioned in the introduction, but it works well for us. once you flip it, then now you return it inside, and you unflip. Sorry, that should be the next slide. Unflip it, and then you remove it. The next step would be now to introduce the guiding sutures. Sorry. Okay. I wasn't moving the slides up for that. Now you can see the inner part of the socket, the wider part. So the next step is now using the guide sutures. Usually this is very tricky, because if you miss and it doesn't go into the socket at the right place, finding the tunnel again at the cortex is usually very troublesome. So this is one area where you should maintain a concentrate that you don't lose it. So now you've introduced the suture, you pull it out and anchor it outside, and then you can go and go for the tibial socket using the landmarks I mentioned. If you notice, in this particular case, we were trying to preserve the STL fibers for various reasons. It increases the robustness of our fixation, to maintain some proprioception, and so we expect better outcomes with that. So we are going now for the tibial socket. Again, once we identify the place to place the socket, drill from outside. This one, it comes out at the tip. This particular one comes out at the tip. I've not used the elbow ones, but some that come out of elbow. So this one comes out at the tip. Again, once inside, you flip it, then you reverse, you drill in reverse. So usually it's around millimeters before you flip, and then the larger diameter is determined by the size of the graft. Usually, we try not to go below 8 millimeters of graft. If you get 10, it's good. So you just try to clear a bit of the soft tissue so that your graft can have a smooth passage. But as you can see, we are trying not to excise the entire ACL remnant. We just clear the soft tissues so that the graft can have smooth passage. Then now we pass the suture. We try to hold them together so that we don't get a tissue bridge in between. So we hold the one from the femoral socket, the one from the tibial socket together, pull them out through one portal, and then we secure them outside the joint. Then maybe sometimes you need to, because you need to enlarge the portal sometimes, especially if the graft is big, so that the graft passes without hindrance. So we are just leading the graft under direct vision the femoral socket. Once we've pulled, then we flipped. We can't see when the endobaton is flipping the outside, but we flip and then we pull just up to the place where we put the sutures. At this point, we don't tighten it. Don't tighten it because we still need to go into the tibial socket. Much as it's a socket and we expect it will be around 25 millimeters. Sometimes if you pull too much, then you might reduce what you will have in the femoral socket. In the tibial socket. So you need to be very careful. We'll tighten once we've secured the tibial side. Yeah. So so now we've secured the tibial side. Yeah, so we've secured both endobuttons have been deployed. We have our graft now. Then at this point, for me, I usually do it in full extension. So I secure it in full extension, make sure we pull alternately on the sutures, tighten the graft. Then after that, recycle and we put it in extension and tighten again. Usually if we are doing, we are just testing the robustness of the graft. It's robust, it looks good. Usually if we are done maybe a meniscal repair, we sometimes put the sutures and then once we've dealt with the ACL, then we go back and now tighten the meniscal sutures. Yeah, that's just a study from 2017, an analysis that compared the open versus arthroscopic ACL reconstruction. But the significant finding was that most of the scores are similar, but what they found reduced was immediate postoperative pain. Personally, I've not done many open repairs. The first I assisted when I was a resident was open, but most of the time we've done the arthroscopic ones. Thank you very much. That marks the end of my presentation.
Thank you very much, Dr. Thank you very much, Dr. I didn't properly introduce him. He's Dr. Were, a consultant, orthopedic and trauma surgeon, very adept at arthroscopic surgery, and he serves the country through the military. So he's a military doctor. Kwa hivyo hata kija kutusumbua atatoa.
Thank you for the further introduction, Asante Sana.
Do we have any questions for Dr. Yes. We are proud of him.
Thank you very much, Dr. Were. You talked about arthroscopic reconstruction of ACL in children. Could you kindly comment on that? What techniques do you use, and what are some of the precautions that you take, because we know that children have got these open growth plates? Thank you.
Perhaps we can have 2 or 3 questions and then he answers them as a block. Yes, young lady. Yes, there is also I'm being reminded that there is a talk on pediatric as well tomorrow.
Thank you so much, Dr. Were. I would like to ask you to elaborate on any landmarks that you use arthroscopically for the ACL femoral tunnel. How do you know you're not too posterior? How do you know you're not too inferior to avoid, like a breakthrough? Thank you so much.
Yeah, that's a good question. Residents.
Sorry, could you repeat, please, the second question?
What landmarks do you use when creating the femoral tunnel to know that you're not too posterior? Yes, thank you so much.
Okay.
The problem of posterior blowout when you're creating the tunnel. Maybe one more?
Thank you, Dr. Were, for that. This is Dr. Kale. I just wanted to find out, are there times you get patients with partial tears? Maybe one bundle is intact and the other one is torn. How do you go about those? Thank you.
So, Dr. perhaps you can answer those.
Okay, thank you for the questions. I believe the first one has been answered, but what I can just mention is that we avoid the growth plates. So you can either, the methods mostly used are the ones where you can use the ITB, for example, go extra-articular. But if you, from extra-articular to intra-articular. But if you do what, for example, I was doing, then it's usually advisable you can stay epiphyseal, both on the tibia and the femur. Epiphyseal on the tibia, and you avoid the growth plate. And usually in that case, sometimes the using intraop radiology would help. That will further in the pediatric reconstruction, but that's generally, we just avoid the growth plates. The other thing also, it depends on the age. If you have a slightly older child or adolescent who's approaching adulthood with maybe 1 or 2 years left of growth, then you can just do redo. The second question on the landmarks of the femur. Yes, as Malim has correctly mentioned, we need to avoid blowout. Usually, you need to give a distance to the posterior end of the condyle. Usually, at least around 7 to 10 millimeters. We avoid blowout by also the direction. If you noticed, we direct it towards the lateral upper thigh. So if we have that gap, then we are not likely to get a blowout. But yes, if you go just posterior to the lateral intercondylar ridge and get your direction right, you are not likely to get a blowout. The third question again?
The third question was on partial tears. Partial tears.
Yeah. I do actually. Usually, what I do, I check how robust the ACL is. Most of the patients I operate on need to be active, and we need to have a functioning ACL without a breast. So I test. One thing clinical, you've already checked the stability, and you do an EUA. But now arthroscopically, you might find you have a partial tear. If clinically the patient felt stable and when I test with the probe, I find the ACL is holding strong enough, I won't it's weak, or the fibers. Sometimes we find an ACL that the fibers are quite loose, or in some cases, if maybe it has been constructed before, you might get the position of the socket or the direction, you find a very vertical ACL. Then in those cases, I would shave and do a reconstruction.
Thank you, Dr. Ali. Do we have any more questions? Okay, just before I hand over, first of all, I would just very quickly like to thank Dr. Noel for inviting us to TZ. It's very nice to be back in Dar es Salaam after so many years. And it really looks like the airport. So I would like to now invite Dr. Kisanga, who I'm familiar with. He visits us in Nairobi every now and again, to introduce the next speaker. Dr. Kisanga.
Thank you, Dr. Mutiso, for supervising this. Now we are heading on with our presentations. I would like to introduce to you Professor Maki Lutomia from Aga Khan Hospital, Nairobi. He will take us through the ACL injuries and the clinical presentation. Professor Maki, karibu sana.
Thank you, Doc, for that introduction. I have a few slides to share with you on clinical presentation of ACL and how we go around making the diagnosis. I think it is important to note that there are a few differences in the way an ACL injury will present in a child compared to an adult. Most of the time in children, the story, apart from it being a sports story, most of the time you'll find that children might not have a very clear injury portfolio. So it is important to evaluate a child with a swollen knee considering an ACL tear. We miss a lot of ACL tears in children because of waiting for the story of football with a pop in the knee. Children rarely present with that kind of story. So if a child has been having whatever, cycling or has fallen, and the knee keeps on persisting, swelling after a few weeks, it is important to consider ACL injury. The typical story the book will tell you for adults is they were playing sports, maybe rugby or football, then there was a tackle, and then they will usually talk of a valgus stress on the knee. So when a footballer or a rugby player steps down, plants the foot on the ground, and maybe there's a tackle from outside like this that sends the knee into a valgus position, or it twists. That is the quintessential injury that causes an ACL tear. I must isolate these kind of injuries with the ones that we usually don't discuss in such fora, which are related to fractures, because we have a lot of ACL injuries that attend fractures of either the femur, distal femur, or the proximal tibia that deserve a special talk. So, as I've mentioned, there is notable differences between children and adults in the way they present, and beware of the persistent knee swelling in a child. The other thing is that we are always told that their ligaments of children are stronger than their bones. I don't know whether that statement is always true, but it is true that children will usually present more with avulsions, let's say like the ACL insertion of the tibia, and you could miss those ones because sometimes X-rays are not able to show the ones that are not displaced. So beware of the child with a swollen knee. In the acute phase, it is the presentation is usually tricky to pick because there is swelling and pain. And when there's swelling and pain, most of the tests that you're taught to pick out ligamentous injuries around the knee don't work because the patient will not cooperate. And some teaching was that you can, and I'm sure people still practice, people put lignocaine inside the knee to obtain some kind of cooperation test. I think with the kind of radiological investigations that we now have, it is usually not necessary to do that, and we don't like putting injections or needles into the knee for fear of infection. So in the acute phase, you might have to wait for the swelling to come down before you do radiological investigations or before you attempt clinical testing. More and more we are going towards early radiological diagnosis and making it easier to pick these injuries. So these children, all of us, okay, not all of us, many of us in my age and beyond, this is how we learned how to ride a bicycle. You remember this? Now, in our days, there were probably, I don't know, maybe there were no bicycles for children. So we used to steal Mze's bicycle, and then because the bicycle is too big for you, you put your limb in between, below the beam there. And this kind of injuries, you'll see them in the villages, and children come with a swollen knee. Many people will give them Brufen, and these people will limp into adulthood. And sometimes the ACL has fused onto the PCL. They have some semblance of a normal knee, which is not quite normal, that keeps on complaining. So beware of children with a persistent swollen knee. For adults, I've explained, usually it will be a pop at sports, and then most of the time the story will be that the sports person is not able to, or the player is not able to continue with the sports. After that injury, they felt a pop, and now they were not able to continue. They had to be carried off the pitch. Most of the time, you know that ACL is torn. Typically, you'll be told that the ACL tends to bleed. There are many other things that can bleed in the knee, but it's one of those things that you mentioned when you're asked when you have a hemarthrosis. How soon does it develop? Usually quickly, and then it will give you sometimes a tense hemarthrosis. But there are many other things. There could be fractures, there could be other tears of the outer meniscus that can also give you a hemarthrosis, patellar dislocations. So, but for registrars, that is one of the things that you will mention, giving you a hemarthrosis that is tense. Now, when you examine an ACL patient, most of the time when they come to the office, they will either be protecting their knee or the way they walk. Some of them will come with a brace on the patient, will walk with the, most of the time, it's not common to find a brace that has the side struts like that. Most of people get these supports. So they come in with the support. But one of the things the ACL does is that it stabilizes your knee when you go into extension, preventing the tibia from gliding or going anteriorly, or the femur gliding backwards. So because now you have torn the ACL, in the full extension you become very unstable. So these patients, when they walk, you find that they compensate the lack of the ACL by tightening their hamstrings. So in that case, in full extension, the hamstrings don't give you good mechanical power. So in this position, the hamstrings are very powerful. And in extension, you're unstable. So they tend to walk without full extension. So they have a walking gait that is not going to full extension because they are trying to stabilize the knee because of the injured ACL. When a patient is walking like that and has an effusion, and then you ask them, most of the time the history, they tell you that the knee is not stable. So we usually ask, do you trust your knee? So the patient, what do you mean? Can you take a staircase with your eyes closed? Do you trust your knee? Or will you lead with that knee? Then they tell you no, it gives way. And you know that there is a problem in terms of stability. And then when you examine that knee, aside from the effusion, you'll usually be told how to look for effusion. Most of the time the effusion will be visible, but if it becomes chronic, sometimes you have to look for it. Squeeze it out from the suprapatellar port and do a brush test where you brush off the water from down, empty, and then wait for the effusion to fill up again on the medial side. It's called the brush test. But more importantly, when the patient lies down, and if you're able to tease them and the limb goes straight, if sometimes you're lucky, but most of the time it might not go very straight, then you notice when you tell the patient to fire the limb up straight, they fire it and they don't go straight. They reach somewhere there. They're not going to full extension. And the reason is, number one, as I said, in full extension, there is that instability, and then they lose the control they had by the hamstrings. Number two is the quadriceps has gone into some kind of inhibition. After injury inside the knee, you sometimes get what is called arthrogenic inhibition of muscle contraction, quadriceps. So the VMO and the quadriceps becomes a bit weak, so they can't fire the full extension of it. So they reach there, they cannot lift it. And then when you feel the bulk, aside from the fusion, you try to feel the bulk of the quadriceps, there is some wasting of the quadriceps. Within 2-3 weeks of injury of the ACL, because the patient has been protecting the knee and he has not been getting full extension, the VMO goes to sleep and you start getting some kind of wasting. So it's important to pick that clinically, that wasting of the quadriceps. And then it is good practice, or at least in academia, to read all the tests that you can do for ACL rupture. But in practice, we don't do that. You develop over time a series of tests that you do for a single ligament. So you don't have to do all the 5 or so tests, maybe if they are for ACL. You probably choose which is the best test that has been validated, that gives you consistent results. And in general, for the ACL, we know that the most sensitive specific test is the pivot shift test, but you cannot do a pivot shift test in the clinic because the patient will not be relaxed to give you that chance. So the second best test is the Lachman test. So we usually, unless the patient is very heavy, in which case you are unable to hold to do a Lachman test, most of us will do a Lachman test, patient relaxes, and then you hold the picture on the left is talking about the wasting, I've already explained. The picture on the right is giving you an idea of how you do the Lachman test. I have found myself that sometimes I tend to hold, the closer I hold towards the patella, the more I have control of that knee. When you hold away from the patella, sometimes tissues are moving and you don't know what is moving. So I tend to hold close to the patella because the patella fixes that femur very nicely. And now, when I hold the proximal femur, I'm a tibia, I'm able to know what is moving. Very, very important to compare both sides. So a good thing to build the confidence of the patient, you can start by testing the good side. Then the patient tells you, no, I'm not sick on that side. You say, I know what I'm doing. And then you see how it ends. It is important to get a hard end, a firm end point. An empty end point is a sign that your ligaments are torn, grade 3. And a lot of literature classifying or grading how much Lachman you're getting maybe has a relation to how many bundles you've torn. But generally, you'll be able to pick up a good difference between the two, and you know that your ACL is torn. One of the things that one needs to be clear, sometimes these injuries don't happen in isolation. You don't just get an ACL tear, or a meniscal injury for that matter, or an MCL. So these injuries are sometimes combined. And so you might find a knee has a PCL, ACL, so it is playing both backwards and front, so you are unable to pick which is. So it's true that some of us, we have even gone to theater thinking you're going for the ACL, you find it's the PCL, and vice versa. But that's why generally you need to know which side is giving you the soft end point. But don't be surprised when one day you go to theater, you find that the ligament you thought is injured is not the one that is injured. Important, if you have had a knee dislocation, you have injured a lot of ligaments. Sometimes you can have a pseudo ACL tear because you are reducing it from a PCL torn position. Then it is giving you a false impression it is the ACL. So, which means in the end, even after all this clinical testing, then you go ahead to do X-rays. Radiological investigation. It is good practice to start with an X-ray because number one, things like avulsion fractures can be picked. Like in this, the X-ray on the left that shows the insertion of the ACL avulsed in this child. You can pick that, and then you can be able to plan. Of course, you'll go ahead in the current era to do an MRI, but at least you'll have picked that. The other thing that you can pick on an X-ray is if there are fractures of the patella, fractures of the condyles. You can also pick a fracture that is mentioned as a sign of ACL tear. which tends to happen at the lateral aspect of the tibia there. You get an avulsed fragment there. It's called a second fracture. And that fracture is commonly associated with a tear of the ACL. People say that that fracture is related to this attachment of a ligament there called anterolateral ligament. Whether it is true or not is a matter of debate, not for this forum. Then you go ahead and do an MRI. The thing you are looking for in an MRI, if you are thinking a torn ACL, if you look at those two images, then you see on the left, you want to see that black belt running from the tibia all the way to the femur like that. But when you see an empty mid portion of the tibia like that, then you know that the ACL is absent. Please remember the ACL is not just straight like this so that they are doing a cut through it like that. So it's oblique. So sometimes they'll do a cut here, they catch it here, they catch it there, they catch it there. So you might see and think that it is torn. So you have to do several views, sagittal views, coronal views, and then you have to learn how to use this MRI in such a manner that you follow that thing up to the bone. So as they are making these cuts, maybe you might see it there, as you follow it until you see where is this thing really attaching on the bone. And then where it is attaching on the bone there, if there is no signal, then you know it is intact. Sometimes when the MRI scans, the scans have been planned very well, you are able to see a very nice all black line like this in this case. It is not always like that. So you have to learn how to navigate through those. I think it is important to mention, like in Kenya we had a big project where the government bought MRIs for public hospitals, almost all of them. But they bought inferior, MRIs, 0.5 Tesla for all district hospitals and what. So we are not talking about any MRI. I think it is important to have good quality MRI. And for knees and particularly shoulders, the more you go like towards the small joints, wrists and stuff like that, when you're doing MRI, you need 3 Tesla, minimum 1.5. For the knee, you need at least 1.5 Tesla. These low Tesla machines, sometimes you'll miss this. You just get some mosaic kind of pattern and then you miss these injuries. Then lastly, to talk about the other things that you see in that MRI that help you think, or you either look for them or you know they indicate to you that most likely there is an ACL tear, even if you didn't pick the ACL. Number one is bone bruising. The bone bruising that is specific for ACL tear is usually the posterior tibia, posterolateral tibia, and anterolateral femur. So you see, like in this case, you see the because what happens? The ACL is running there like this obliquely. So what happens when the pop happens? This tibia moves forward. This tibia moves forward. So what? Because it's moving forward in flexion, the lateral side, the lateral condyle of the tibia hits into the femur. So you get bruising that is usually very specific at the posterior lateral tibia and the anterolateral, what is called the sulcus. It's called, the anatomists, they call this sulcus what? This area of the femur has a name, sulcus something. I forget. That bruising is very specific for ACL tear. Even if it is not complete, you will know that the ACL was going to tear. So maybe there's a single bundle or something like that. When you see that pattern, congruent bone bruising. Number two that you should look for is the meniscus. After you see the ACL is probably torn, and you see that bruising, then you look for the medial meniscus, the posterior horn of the medial meniscus. The posterior horn of the medial meniscus, you have to run, you see those diamonds and follow to that where there is an arrow there and see if there is a signal of fluid passing between the capsule and the meniscus. Then usually there is a posterior meniscal tear. Be careful that there is usually meniscofemoral ligaments there, right back or something like that. But usually if that signal is complete and continuous with the lower one, it means that there is a tear there. Some of them that are called ramp lesions. And failure to detect these will lead to poor outcomes, because when you are treating that ACL, you are treating it, one of the structures that will help you save that ACL for stability on the medial side, remember when the first lecture was said, was medial meniscus. You need that medial meniscus intact, and missing the posterior horn will cause lower outcome scores. And of course, the second fracture that I had mentioned. Thank you very much.
Thank you, Professor Antonia, for such a elaborative presentation. So, if there is any question, in the audience, yes.
Thank you so much, Professor, for a very elaborative talk. My question is, there's always been a lot of controversy around when to do the MRI when someone has a knee injury and suspecting ACL. When do you suggest that the MRI should be done?
Thank you. So there is the perspective of the orthopedic surgeon, and then the perspective of the radiologist, and then the patient. Yeah? For a patient, some patients, you can't tell them, I'm injured today, you come to Aga Khan, I'm going to do an MRI after 4 weeks. They'll go to Dr. Mutisa in Nairobi Hospital and get the MRI done, and they think you're not a very serious guy. So there is a lot of, so let's see, if you do the MRI early, let's say day 1 of the injury, what are the things you are likely to get? You get a lot of artifacts. So number 1, you have to talk to the patient to explain why you may not want to do that MRI that day. If you don't talk to a patient, and you notice, if you're working in a public hospital, maybe the patient is not able to afford to go to another doctor anyway. But if in private, these matters become very important, how you talk to the patient. You have to explain to the patient that if I do it day 1, we'll see so much stuff, most of which I will not need to address anyway. Because the blood, but the radiologist tells you, if there's bleeding, it's very nice for me. The bleeding is good for me, it's contrast. So I'm able to pick literally 100% all the injuries. But truth be told, in 3 weeks, most of those injuries have healed. The MCL has healed. Those that are going to heal, most of the bleeding has gone down. Now you can be able to know what exactly is injured. Anywhere between 3 to 4 weeks is a good time to do an MRI. But you have to talk to the patient, explain why you are doing it after that time. Otherwise, the patient will go to the next available doctor.
Any other question, Dr. Sabas?
Thank you so much for the good presentation. Also, because in our setting, we also see patients, sometimes they come 3 weeks after the knee injury, some come 6 months after the knee injury, some 2 years down the line after going around to the doctor, the traditional healer to the surgeon. So I was concerned about the good sign that you say, most of the time you find it that the anteromedial on the anterolateral on the femur, and that's bruised, and the posterolateral on the posterolateral on the tibia. Till when you have to see, is it throughout? And I think that's when you expect to see them.
Bone bruising healing rates are different. But take a bone bruise like a fracture, basically. A bone bruise is equivalent of a fracture, just that it's an impaction kind of fracture. So fractures heal in what? Anywhere from 4-6 weeks so onwards, but it is usually present even at about 4 to 6 weeks. You'll still pick it. That's why 3-4 weeks is a good time to do MRI. But there is a new, I think in another forum maybe we can discuss bone bruising, so-called bone edema, because bone edema is a new phenomenon now that we are thinking some patients just get stuck into that phase of bone edema with some kind of pain that is not going away, and even interventions for that is another discussion altogether. So for this time, we're just looking at it as one of those extra things that you can help you to know that there was an ACL tear.
I think mine is just a comment about the MRIs. I think it is important to learn how to read MRIs. I don't know whether we have a radiologist on board, but with due respect, radiologists do from hair to the toenail, the whole body. We don't have specialized, we don't yet have specialized radiologists who specialized in one area. So it's good to learn how to read the knee and show the MRIs. You will be surprised how many things you pick which the radiologist doesn't pick. So that's quite important.
There's another question for us.
Thank you, Prof. I don't know whether I'm preempting the discussion, but I'm just wondering about, the first presenter talked about the SEL being double bundled. What's the current thinking in reconstructing? Does it really matter clinically whether you put in a single bundle or double bundles, or it doesn't really matter at all, just for interest sake? Thank you.
Most probably that's a discussion for the whole faculty. Maybe towards the end, as we conclude, we'll have personal opinions. I can tell you, if you sample the faculty, you'll probably get as many opinions as there are. I think the literature clearly says there is a double bundle, but the clinical outcomes of a well-done single bundle reconstruction and the double bundle reconstruction are not there's no difference in the outcome. So when you look at the technical know-how you require to do double bundle reconstruction and the time you will spend, especially if you are not a regular doer of that, you find that very many surgeons don't do double bundle reconstruction. I think it's for the few who are so keen on it with no extra outcome benefit that are able. So you find these conferences where people are talking, I do double bundle, others do single bundle, but when you do the final outcome scores are just the same.
Okay. Yeah. Oh, sorry. No, I was just going to say, in our locality also you have to think about the cost element. As the literature says, in the long run, the difference might not be that much, but then the cost element of a double bundle compared to a single bundle is quite huge. And double bundle, the late Professor Freddie Fu, I think is the one who was popularizing a lot the double bundle, but he had all the resources, so he could just do a lot of that. Maybe Prof.
I'll just comment on, I think what Dr. Kala said is true. The same Freddie Defoe, the late, did a very good study, cadaveric, which showed that there was no difference between double bundle and single bundle reconstruction. However, there's a difference if you're talking about persistent laxity after single bundle. There's that advantage of having started with a double bundle reconstruction, because it does not address the persistent laxity that may be there if the bundles are not in the correct position. And that is why now there's a lot of talk about anterolateral ligament ALM reconstruction or extra-articular tenodesis to try and address that extra element, which actually today is elephant in the room. Whether on top of doing ACL reconstruction, do you need to do any extra augmentation?
There's one question also there.
Okay, I have a question. Most of the time when you have a patient who sustained the knee, and that patient presents maybe with the features of fracture, we are dealing mostly with the fractures and not ligament injuries. So how do you go when you have patient with maybe tibial plateau fracture or distal femur fracture, and you treat fracture, and then later on you found this patient had the instability of the knee? How do you go about it?
I deliberately avoided that. I mentioned and I disclaimed it, and I was hoping no one will ask. Maybe I shouldn't have mentioned to wake up your question. I think the protocol, when you have an injury with a fracture, luckily most of the time it is usually an avulsion from the base, like a Makiva type of injury. If you are going to open the knee and you have the technical know-how to do it, if you can capture it with a fiber tape, you can actually tie it in the mess of bone that you'll be creating. It is not easy. So most of the time, what ends up happening is we fix the fracture, and then the SEL will be resting at the base, you know, if there's a fragment of bone, maybe hopefully you've captured it in the mess of sutures and held it down. And then when it heals, most of the time there is some kind of laxity, but it's not so clinically significant. If it remains clinically relevant, then you can remove those implants after about a year and do a proper reconstruction. If it continues to be, because it's not always that you don't have an ACL, you're going to need surgery. It's not 100%. So you must follow up those patients and see those who will require, they still have laxity, then you can remove the implants when the healing has happened, and then you can do a reconstruction. So, but at the time when you're doing the open, after you've done the exposure, say a Schatzka exposure, you've lifted, you've seen it, if you are able, you can capture the ligament and sink it with the bone in the mess of the grafting that you've done there. The only thing I wanted to make comments to my colleagues is, books talk about size 8, size 9, size 10 ACL. I have been doing this surgery for ACL for now, 12 years or something like this. I have hardly in our population found ACL. In fact, I think I can count. Maybe only 5 times or less I have had an ACL that is size 9 and above. Frequently, our ACLs in Africa are like 7, 7.5, 8, 8.5. We are starting to get very rare. But we do them and they don't re-rupture. I don't know, maybe because the sports here is not as active as the West or what. That is number one. The others, so I would like a comment. Is this comment about 9 and above? Whether you guys, when you have harvested both of them, you've quadrupled, you have 7.5 or 8. Will you go for the erroneous longus to make it 8? I think that is something I've always, we've discussed even at ACU, and we are not able to come up with an answer to that.
Or maybe just a quick comment on that. Some of the discussions we're having now are actually for the advanced course, because they are very controversial. I mean, the reality, you have theory and you have practice. For example, for the fractures, if the patient is multiply fractured, you know, there are issues of tourniquets, blood loss, anesthesia, so many things that are coming in that you really want to sort out the bone first. And then remember, when you put your implants there are screws which are going to go into the space that your tunnels would pass. So in the end, really, it is each case as an individual case. You make your judgment based on each individual case, and it's very, very difficult to generalize. About the sizes, I agree. And the smallest ones are usually in ladies, even the big-looking athletic ladies. You go in there and the ligaments are so tiny, so even and the joint itself is small. So the issue of doing double bundles and what becomes more of an academic exercise. And then sometimes you find there's not enough ligament. And once or twice we've had to go add from the peroneal ligament and so on. I rarely do quadriceps. I don't know what it's like for the rest of us. Now, the issue that was being discussed a little bit earlier on double bundles and so on. This is a very complex area. Even the experts themselves do not agree. I'm glad there was a quotation on Freddie Fu. Freddie Fu's paper actually is becoming a classic. It's becoming a classic paper, especially from the time he passed on. That was a loss of one of the very big luminaries in arthroscopy. That area, no two people will agree. I mean, I'll have my series and I make it look like it's the best. Somebody else has a series and it's almost the exact opposite of what I have said. Thank you.
Thank you, Professor Otumbia, for a nice presentation. An applause for the professor here for a good presentation. So we are running out of time, but we will have just a 20 minutes presentation from the Double Medical. They will display some of their of their products here, and I would like to introduce to you the representative of the company, Mrs. Lee. Lee.
Hello, everyone. Mambo? Yes, my name is Lily. I'm the sales rep from Double Medical. So we're also together with Mr. Gabriel, we're the sponsor of this event. And first of all, I'd like to express my gratitude about this cherished opportunity to gather with all of these distinguished surgeons in Tanzania. And it's also my second time to be in Tanzania. So because of time, let's just dive into today's topic. So in the next 20 minutes, I'm gonna give you the introduction about Double Medical, and as well as the overview of the sport medicine products from Double Medical. I'm gonna introduce from the following aspects. So Double Medical is a comprehensive medical enterprise in China, also a listed company in China. We are dedicated in the research and development, producing and service of the high-value medical devices. And under Double Medical Group, we have several subsidiaries, including, first of all, Double Medical Technology. Of course, it's a baby company. And also we have Spy Endos, which is focusing on endoscopy. And we have Surget, which is focusing on minimal invasive surgery. We also have SAC, which is focusing on wound surgery. We have wound surgery, which is focused on SANF and thoracic wall repairment and reconstruction. Last but not least, we have Dental Master. Obviously, it provides dental solutions. So besides subsidiaries, we also have a hospital running under Double Medical Group to let us have a clinic connection with, have a close connections with clinic. So there are some highlight moments in our first decades. First of all, Double Medical Group was founded in 2004, and after that we started the expansion in domestic market and international market. By 2014, our products has exported to more than 50 countries. And also you can saw this was highlighted in blue. We have built those subsidiaries in our first 2 decades, and also we have 4 overseas offices to serve our partner better. Besides, we have certified by several international institutions like ISO, CE, FDA, TGA. Even last year we acquired certifications from MedZap. That means we never stop our steps to pursue the quality products. So this is how our corporate look like. You can see it consists of 4 pieces. The total area has reached 40,000 square meters, and you are most welcome to visit our corporate in Xiamen, Fujian. This shows how our group grew up from only 51 members to nowadays more than 6,000 personnel, and among them there are more than 1,400 personnel from R&D department, QC department, and production department. So here, let's have a quick review, overview about the solutions we provide. First of all, let's look at the orthopedic trauma line. You can see we have quite comprehensive portfolio of products, which including those internal fixation systems like locking and unlocking screw, intramedullary nail, together with the external fixation systems. Our products can can satisfy most various demands from clinic. And it is also remarkable that our trauma products has been ranking for many years #1 in China in terms of sales. So that means in China, the effect of our products has already been proven by millions of cases to support its effect. It's like, let me give you a number. Last year, there are 2,700 trauma surgeries performed every day on average using Double Medical's products. That accounts 30% of the total cases. This is about the spine line. You can see we provide solutions for anterior cervical spine, posterior cervical spine, anterior thoracic number, and posterior thoracic number spine. We have plate and cage system. We have titanium mesh, laminoplasty, pedicle screw systems. Also, in China, our spine products with the most complete, comprehensive portfolio. We rank #1 in China in terms of sales. This is our another subsidiary called Spine Endos, which was a German company we acquired in 2021. Now they are focusing on endoscopy equipment. Here, for joint, we are focusing currently on knee and hip and shoulder. There are some solutions for small joints are coming up. Okay, here we are in sport medicine. We also have a very comprehensive portfolio for sport medicine, and later I will give a specific presentation about this chapter. So let's go to the next. This is the solution for our another subsidiary called wound surgery for CNF, and this is for wound repair, wound care. This is for minimal invasive surgery. You can see we have choker systems and something else, and dental implants and dental instruments. That's all about the overview of our product solutions. So what we want to introduce more is about our research and development system. So last year we have spent 9% of our total annual income in research and investment team. We have built a team more than 600 personnel for R&D department. So far we have acquired more than, I think this number should be updated, more than 500 patents product certificate. This is the direction of our innovation. For new production method, we are developing 3D printed cage, 3D printed prosthetic. For new mechanism, we have developed expandable cage and expandable vertebrae. For active system, we have knee soft tissue pressure spacers, resistive pedicle screw opener, even the robot-assisted machine to help our surgeons do the cutting during arthroplasty. So since establishment, we have been paying much attention on the cooperation between technicians and the surgeons. So these are 4 products that we hatched between Double Medical and those renowned surgeons around the world. The first one is from a very famous Chinese surgeon called Zhang Yingze. The rest 3 are projects cooperated with those Australian surgeons. Those products, we work with those surgeons and bring their idea into reality. So if you have such idea, you want to make it control and serve the clinical better, Double Medical, we are capable of bring it into reality. Now let's talk about the quality systems. So as I just mentioned, we have certified by so many international institutions, also got those basic or international standards that ensure our company sell our products to different countries, no matter it's high level, middle level, or low-end market. Each of our products before it enter market will go through the biomechanical testing to make sure it function reliable inside human body. So apart from domestic one, we also cooperated with another 2 international collaborated laboratories that are also widely recognized around the world. So this is our factory picture. You can see there is, you cannot see people here because it's automatically produced. We introduced the most advanced equipment from German, Switzerland, even Japan. Each of them might cost millions of dollars each, and we have several of them. So, and we established the most advanced management of the production systems. Speaking to raw materials, we are quite we are quite picky about the selection of the raw materials. We are share the same raw material suppliers as those giants in this industry, like Medtronic, Synsys. We are using the same material suppliers, and we are using the same technique. That means we have the same quality products, but we are in economic class. So this page is about the business performance review in the past 15 years of Double Medical. You can see it's experienced a very dramatic growth in the past 15 years. That is very impressive because like 10 and 15 years ago, Chinese market is dominated by those foreign brands, but nowadays Double Medical already catch up with it. From this picture, you may see more clearly how we achieve that in China. So in China, we have supplied more than 5,000 hospitals, and we built a very strong team, a strong marketing and sales team of almost 500 personnel, and we have 180 warehouses in 30 provinces in China. Besides, we also developed an online proprietary platform which can serve the logistics supply better. This is about the global markets. So far, we have exported our products to more than 60 countries. And as I said, we have 4 offices there in Chile, Greece, Singapore, and Ukraine. And in the future, we will put more attention in African countries. So that means we can have more resources in African regions. We also built a Double Institute, which provide a platform for surgeons to maximize their skills and also to teach the fellows how to do the surgeries with various subjects covered, like trauma, spine, joint, sport medicine, etc. There are some real shooting pictures about the institute. You can see we equipped with them all necessary facilities like thoracic facilities and simulation operation rooms. And the simulation operation rooms, every week we will have doctors, we will have surgeons to do the animal surgeries to teach the young surgeons about how to do surgery. So, and also we have this small operation room, which is almost the same as the one in hospital. This page is about the international academic exchange activities we have been organized. You can see we have academic exchange between hospitals. It is regular hold. We will invite, like for example, we will invite surgeons in our market, like in Africa, to China to do such regular visit and exchange. Also, we have conference, we have workshop and demonstration, we have Cadavic. We had Cadavic in Croatia and Russia, and this year we will have Cadavic in South Africa. So this basically about Double Medical Group. Hope you have a basic understanding about what Double Medical is, where we come from, and where we aim to reach. Because of time due, without much delay, let's just dive into the total solution of sport medicine from Double Medical. So basically, our solutions can be including implants and non-implant part. Yet for implants, we have suture anchor system, cruciate ligament reconstruction systems, and also trauma application bottom plate system, non-observable suture systems, last but not least, meniscal repair systems. For non-implants, we have arthroscopic supporting implants, arthroscopic equipment, and relevant consumables. And this year, we also developed a central fusion device for producing PRP. Later, I will introduce more about this new product. Now let's look at the suture anchor system. So we have the suture anchor system with different materials, including metal suture anchor, PIC suture anchor, and all suture anchor. So our metal suture anchor features its design in thread. We have the high and low dual threads, and dense and sparse threads, full threads, and deep threads. For PICC suture anchor, you can see here we also have diverse products which can satisfy the clinical needs. For all suture anchor, we have keynote and U-knot. These are some common features of our suture anchor. For insertion handle and suture part, which features ergonomic handle for surgeons to achieve better grip during operation. And we have the blue and white colors of suture, which can achieve better distinction under endoscope. For anchor part, we also have those features enable our products more outstanding. Here, I would like to highlight two products which are our patent products. Number one, locking suture anchor. This one can be used together with our trauma plates. And the second one is double fixed PICC suture for anchor, which features it has a special pre-assembled suture inside the anchor, which can create locking ring structure that enables surgeons to reduce the number of tie knotting during operation. So in general, our suture anchor system can cover all types of clinical surgeries with the complete specifications. And besides, it can also treat some special indications like the joint injuries in pain and the fixation of humeral greater tuberosity fracture. Now let's look about the cruciate ligament reconstruction system. We have an adjustable bottom system and interference screw which can suit for different fixation, like suspension fixation reconstruction, all-inside reconstruction, and PICC interference screw reconstruction. So there are some features like base design which can increase sealability. And we have multiple optional specifications. And the bottom is features open groove combined with a loop for suspensory fixation. And the titanium plate, we have the one with 3.5 millimeter, which can pass through the bone tunnel of 3.5 millimeter. Besides, we also have interference screw with sheath or without sheath. This is an all-inside instrument set. Our flip cutter reamer will provide the short one with length 265 millimeter plastic handle and long one with length 355 millimeter metal handle. This is operation steps. You can also find our operation steps on YouTube in our official double medical account. Let's look at the trauma application bottom plate system. So this one, we have adjustable bottom for plate systems. Yeah, and also the one for syndesmosis. And also we have mini adjustable bottom for reconstruction of joint, of ankle and tendon, and some injuries in small joints. These are some instruments and surgical slabs. Here we come to the non-observable suture systems. So in general, we have a very complete specifications about suture type. We have the round one, we have tip one, we also with or without needle. We have suture loop, and they have different colors. Those colors are available to ensure the distinction under endoscope. Compared with our products on this market, according to the test result, our products have the better tense strength. For meniscal repair system, yes, we have all inside the meniscal system with curved needle. There are instruments and implants here. This is operating step. You can find it on YouTube. So for those non-implant part, we have arthroscopy supporting instruments, including cannula for establishing tunnel, and we have a suture passer. We have grasper for shoulder knee arthroscopy. So For arthroscopic equipment and relevant consumables, we have developed the tower systems consisting of imaging machine and shower system, RF system, and pump systems, together with the relevant consumables, including shower and disposable plasma ones, which is compatible to other brands' machines like Smith & Nephew and Athrax. Here we come to PRP. This is our new product we launched this year. It's a central fusion device which can produce PRP. And you may find the same products on market already, but our products distinguish our machines by achieve the less operation time. It's like 60 seconds, you can finish the rotation, separation of the whole blood. And the total operating time is less than 85 seconds. So that's all about our solutions for sport medicine. I think compared to my presentation, you may be more interested in touching these products. We already display our implants there. You can come in front and have a look. If you have more questions, you also please feel free to ask me here. Thank you.
Thank you, Mrs. Lee, for a nice presentation. I think we have heard her, and there's some products here from the company here we can just see, and you can ask them some questions if you have some questions to ask them. So,
yeah, we have brought the solutions sample products for 4 lines: trauma, spine, sport medicine, as well as joint. They are all here. You can come and touch the products.
Yes. I would like to announce to you we have arranged our after lunch. We'll be going to theater in the wet and dry lab. So you have some groups. You have been given from group A to group D, and group A will be under Professor Lutomia, Dr. Joel, and me, and this one will go to all the ICU. Group B will be under Dr. Sabasi, Francis, and Dr. Kale. Will be in table 6 in theater, and group C and group D you will go to wet lab and dry lab, and this will happen after lunch. So you can just pass the instruments which are here on the table, and then you ask them questions.